Okay, so this is our second podcast. We did our first podcast with Mr. Sam Singh and we talked about Achilles ruptures. Today, we're with Mr. Martin Klinker, who I've worked with for definitely over 10 years. And what we're going to talk about today is actually an area that we see an awful lot of and we share a lot of patients, which is forefoot pain. And we'll talk a little bit more about what that means. But Martin, do you want to give us a bit of an introduction as to where you work, etc.?
Yep. Thanks, Chris. Martin Klinker is my name, foot and ankle surgeon, so orthopedic surgeon, but I've also got a degree in sports medicine. So I'm very interested in dealing with a lot of runners, forefoot pain, that's why we're talking about it. So I work here at Londonbridge Hospital. I work in a few other places. So I belong to the London Foot and Ankle Centre. I belong to the Londonbridge Orthopedics and Kensington Orthopedics across London, but my main base is still here in the Shard. So I see the whole spectrum of foot and ankle pathologies, but there's a lot of forefoot issues going on, especially during lockdown and after lockdown, the runners, because you couldn't play football, squash, or whatever. You had to go running or cycling. So I saw a lot of forefoot problems during that time. People who normally wouldn't go running, they started running because that's mostly the only thing they could do.
It's what everybody started doing, isn't it? With lockdown.
No ligament injuries. It was all linked to either Achilles tendon because they did too much too soon, not necessarily ruptures, but overuse and forefoot overload.
Yeah. And we've seen lots of patients, haven't we, where actually they're probably keen runners or they do a lot of walking and they are getting a lot of forefoot pain. And what does seem to occur is that they become quite chronic. So they're not that easy to fix. Often they've done the sort of simple things, a bit of rest, but we certainly see a lot of patients that, 2 years down the line are still getting quite a bit of forefoot pain. So for the layman, what do we mean by forefoot pain?
Well, there is that description of metatarsalgia, which is not a real pathology. It is a summary of pain in the metatarsal area.
Yeah, so the metatarsal area, we don't have a foot, I don't think, but it's basically the ball of the foot.
Exactly.
In between the sort of long bones, but not down at the toes.
Not the toes, but it is across the ball of the foot, indeed, yeah. So there are quite a few structures in a very small area. And also when we walk, when we run, a lot of pressure goes through that small part of the forefoot.
Yeah.
So when we talk about hips and knees, big joints, they don't take by far as much weight as the ankle, and the forefoot even more so, especially when we do run, when we go up and down stairs.
Yeah. And so I suppose one of the first things that, it should be with any sort of pain that presents, but we're after the correct diagnosis. So what sort of diagnoses would we be looking at around that area?
Well, we at first take a bit of the history. What did that do? So someone who never ran, who started then some running and overdid it probably, might have had just a bit of an overload without any structural problem. So if you were to get an MRI scan, ultrasound scan, you wouldn't see anything. Whereas if they presented with some swelling, that would be potentially linked to an overreaction in the bone. So they could get a stress reaction, which you only see on an MRI scan, not on an X-ray. And you don't need to get that straight away. But if you see some swelling, you should think about a bony issue in the sense of a stress reaction or a stress fracture, which on the other hand, don't get an X-ray too soon if you think there's a stress fracture, because for the first 10, 14, probably even 20 days, you sometimes do not see anything on the bone.
And that's really important, isn't it? Because we see people that have gone to A&E, they've had 3 days of pain, they go to A&E, they get a clear X-ray, but we can't rule out a stress fracture at that point on
Absolutely.
X-ray.
Don't need to get an X-ray. You could, if you thought it was absolutely necessary, could get an MRI scan. You could also do an ultrasound scan. Sometimes on the ultrasound scan, you probably know better than me, you can see something, but you can't see it on the X-ray.
No, absolutely. We definitely pick things up on ultrasound and not on X-ray.
And
And you've started with stress fracture there because obviously that is probably the most common thing that we see with runners. And a stress fracture obviously is a stress fracture of the bone, so it's an overload to the bone. And that really is, I'm sure you're the same, as soon as a runner walks in, that's the first thing you're thinking, because that's the one that really needs complete rest, isn't it?
Yeah. So, the reason why it's called a stress fracture is because there's so much stress. But there might be various links to it. So one thing is, yes, the runner who increases the mileage or did get new shoes or different running surface might get it.
Yeah.
But it could be also someone who didn't do too much, but it's a certain period of life where your bone is getting a bit weaker, so the density or the strength of the bone isn't as good.
Yeah.
And more common in women,
Yeah.
it's a combination of the two. The bones might get a bit weaker, and they increase their running, their walking, they want to stay fit. And the combination of the two makes it more likely that there is a stress reaction or even a stress fracture. They tend not to display, so you wouldn't see that properly on the x-ray. Yes, we treat them conservatively, but we need to know what it is. And when we see a runner and they're swelling, that's the first thing you have to think about.
Absolutely. And normally they get pain walking that gets worse when you start running. Hopping would be uncomfortable, and often they are limping, but not always, particularly if they're wearing quite supportive shoes. And then on the top of the foot, it's probably second, third,
maybe the
fourth, second.
It's not that often the fourth,
Yeah.
But it's mainly second, third. And there are other conditions in the forefoot which are more 3, 4.
Yeah.
So between the third and the fourth metatarsal, whereas stress fractures and overload syndromes are more the second and sometimes the third.
Yeah.
But that's already a good guideline. Where is the pain? Where is the swelling? What's interesting with a stress fracture, often you palpate on the bone and even the next one hurts a bit because it's swelling.
Yeah.
It's not only localized over one bit.
And so that's one of the key diagnostic tests, isn't it? Is that it is acutely tender to press the bone.
Yeah.
And one bit of advice I would give is that if people, do press the top of their foot and they're jumping off the bed, that really does need some rest and it needs medical attention, really, doesn't it?
And especially the bones on the foot, like on the hand, you can easily feel. So press on the bone, it hurts. If it's in between, it could be something different.
Yeah.
And with a stress fracture, there are some conditions, arthritis in the joints a bit higher up. They can cause similar pain, they can cause some swelling, but they wouldn't get more and more painful always when they become active. They're normally painful at the beginning, then it gets a bit better, and then it gets again worse. But they have that period often when it's mild arthritis where once they're warmed up, they can even go jogging. It hurts afterwards. And at the beginning, with a stress fracture, the more you run, the more pain you get.
That's
can't
the
just run through
crescendo of pain, isn't it?
Absolutely,
It gets worse and worse. And also what you find is you go for a run on a Monday, what's that pain in my foot? Give it a couple of days off, go Wednesday, Thursday, it gets a bit worse. It doesn't get better with those few days of rest. So that's stress fracture. So that's one of the things we need to rule out. You've mentioned also osteoarthritis. So do you want to just expand on that in terms of the joints and how they can be involved?
Yeah. What's interesting, we see relatively often arthritis in the big toe joint, but we hardly ever see it in the lesser toe joints. It does exist. If you had an injury, if someone trots on your foot and the joint was injured, you can get it.
Yeah. Or if you had maybe a previous fracture.
Exactly.
Or something like that.
You can get it, but it's by far not as common.
Yeah.
And it's normally linked to something. So it's either a trauma or it's what we call fibrotic disease, an avascular necrosis of that area. It can affect the second or the third. That means especially younger women get it where the bone doesn't get the blood supply, especially the metatarsal head. It crumbles a bit, it reforms, but it doesn't have the same shape. And that can cause pain. And that is something you then see on an x-ray. Early stage, again, you can see it on the MRI scan, probably best. You can see something on the ultrasound scan. But with time, you see it on the x-ray because it's not that normal round shape of the metatarsal head.
Yeah.
So yes, arthritis in the forefoot, big toe joint, a lot more common.
Yeah.
Less MTP joint, very rare, especially on the outside, hardly see it. But it can be higher up in the foot. So along the metatarsals up here, the second or third, that can become arthritic for various reasons. And that can be associated with swelling and with pain, and the pain can radiate. So you might not only feel it around the joint, it hurts more further down the foot.
Yeah. So it just goes to show that, as you said at the beginning, in a very small space, there can be lots of things going on. And also when you start to use terms, as you say, like avascular necrosis, which obviously is a lack of blood supply to the bone, it also tells you that if you have had forefoot pain for a certain period of time, you do need to get it checked out because that can cause long-term damage. It's not something to ignore, is it? Okay, so we've done arthritis. So the other one that we see a lot of is Morton's neuroma, or also intermetatarsal bursitis. And it is very common, isn't it? Do you want to just go through the main sort of signs and symptoms of that?
It's quite tricky sometimes to really know what it is.
Yeah.
So normally the pain is not in the joint. So that's the first thing. It's normally between the bones, between the joints, and it's a lot more often between the third and the fourth. It does exist between the second and the third, but between the third and the fourth is the most common area where patients get bursitis or a problem with a nerve.
Yeah.
So the typical description of it, if a patient comes in and says, when I wear a certain type of shoes, they're a bit tight, they're probably a bit of a heel, but it's the tightness, and it radiates on the toes, there's a bit of a burning sensation, a bit of numbness. I take off my shoes, I move the toes, and it goes. It is extremely likely it's a Morton's neuroma. Could be the bursa as well, which is pressing on the nerve.
Yeah.
It doesn't have to be the nerve itself, and that's even with MRI scan, ultrasound scan, not always that clear what it is, but it's between.
Yeah.
And when you compress the forefoot, and at the
So
same
when you
time
squeeze either side of the foot.
either side of the foot, and ideally put fingers on top and on the bottom as well, so you really put pressure on that small area, that triggers the pain. But it's not always textbook. There might be no numbness, there might be no tingling sensation, there might be nothing. But it's in that third web space. And I recently operated on a young, very active runner, and there wasn't a huge neuroma, but the bones were so narrow there just wasn't enough space for that. And the reason why we think it's more common between the third and the fourth is because the third metatarsal is relatively stiff. The fourth one is very flexible. So the ligament that connects the two is rubbing against the nerve. That's why it's so common in that area.
Right.
It can happen in the second web space, but it's a lot more common in the third. So already where you see it gives you a clear idea it should be this or that.
And people often say it feels like they're walking on that pebble or stone as well, don't they? And sometimes because it involves the nerves, it causes the tingling into the toes and the numbness as well. Okay, so we've gone through stress fracture, we've gone through arthritis of the joint, we've talked about neuromas and bursitis. The last one, which we definitely see in runners, which again can be quite tricky to diagnose, is a plantar plate injury. So do you want to tell us a little bit about how that presents?
What is interesting is, as you said, you feel that the patients describe they're walking on something, but that can also happen with an overload, what we generally call metatarsalgia, but it's normally a capsulitis. It's a problem in the joint. So capsulitis, and they feel like they're walking on something, but it's a different location. It's normally the second MTP joint. And then you have a certain test, the Lachman stress test, where you hold the midfoot and like in the knee, you move the base of the proximal phalanx up and down. And if that reproduces the pain, it's a lot more likely it's the joint. It's the plantar plate. Of course, if there's hypermobility, if it's ruptured, there's instability. But if it's just a bit inflamed, it just hurts. So they might feel that they're walking on something, but it's the joint. And you stress it, and that reproduces the pain. And then you can see how much movement there is. We should always do it on 2, 3, 4, and on both feet, because it's always a strange movement for the patient. They say, ooh, that hurts.
So
but even on the good
to
one,
another one,
even on the normal one, it's a strange movement. So yes, the plantar plate is the structure that goes from the, well, it's underneath the joint. It's like the capsule, but it's a thickening. And
just before where the toes start, basically.
It attaches to the toe.
Yeah.
So as you move it up, you stretch it. And that can cause an inflammation, an overuse of that, and that can cause the pain when you move it.
Yeah.
And you can squeeze it, and that causes the pain. It's not in between, it's really the joint itself. And yes, runners are very prone to that. People who want to wear very trendy trainers, no support in there. I shouldn't mention the brand, but a lot of trendy trainers, no support, but they walk in them. Not good. It's a bit like walking in high heels. You should
like the barefoot brands.
Absolutely.
Yeah.
You can do that if you get used to it slowly, but normally you should try to wear something that takes away the stress from that area, and especially when you spend a lot of time.
Or if you're going to transition over a long period of time, like we're talking months here, aren't we?
Absolutely.
Because you've got to, just like when you start to play the guitar, you start to get thickening of your fingertips. It's the same in the feet, isn't it? You're going to build calluses that are protective to those regions.
Which then can hurt.
Yeah.
So initially they're protective, but then it's always good if the patient doesn't see their chiropodist first and they come in and there's no hard skin. I want to see the hard skin. I want to see how the foot is. So the French call it le piron, that round forefoot. Because the callus can be so thick that you overload and you get all that thickening underneath, but nothing under the first metatarsal. Because often the big toe doesn't take the weight. The big toe might be, the first metatarsal might be too short, there might be an instability at the TMT1 joint, so further up, there might be a very tight calf muscle. All that can lead to an overload of the second, third MTP joint area. And especially when there's a bunion or hallux rigidus, they don't want to walk through the big toe because it hurts, or a bunion, they don't take any weight because the big toe is not in the right position.
So it pushes all the way onto the next
pushes all the way to the
toes.
second, and that's why normally if there is suspicion of being capsulitis, it's the second one if the big toe doesn't work properly or if they overload. So tight calf muscle can lead to that. Long metatarsus can lead to that. Yes, and the runners, they get it.
They do, don't they?
Yeah.
And certainly with a patient we had recently, one of the big things that made me suspicious of the capsule, the joint, and as you say, the plantar plate, was that there was quite a big gap between the second and the third toes. Do you want to just explain that a little bit? So if you're looking down at your feet now and you see a big gap between your second and the third toes and you get pain there, that might be an indication. And often the toe lifts up a bit.
That is very much an indication.
Yeah.
And what's interesting, patients say it's the second and the third that have moved. No, it's normally the second that moves towards the big toe that makes the third one look like it moved outwards. But it's the second one. And that's because underneath and the collateral ligaments, they're stretched out. So therefore it moves towards the big toe. And there's often hallux valgus, a bunion with it. So they don't take enough weight through the first ray, through the MTP joint 1. They take all the way through the second one. That overloads the plantar plate, stretches out. It moves a bit towards the big toe, and therefore there is that gapping. So if you see that, you should think of an overload syndrome in that area.
Right.
Not necessarily linked to bunions and all that, but often in women who don't run. In runners, they come in and they have pain there. You see that splaying, and it's a second MTP joint overload.
It really is quite technical, the forefoot, isn't it, when we talk about it like this? And I think what most people would do is if they start to get pain on the forefoot, they might go to boots. Obviously, there are other shops on the high street, who'll probably go to Amazon these days, and they'll get some sort of padding, won't they? Mm-hmm. But what's interesting when you're talking there is that it's all relative, isn't it? So if one toe isn't working very well, the pressure will go on to the next toe. So that's probably one of the reasons they don't always work, although they may still be worth a go. Have you got any other tips that you can give patients with that sort of forefoot pain that they could sort of self-help tips? You mentioned about stretching the calf.
What is interesting, we mentioned the stress fracture, and even though stress fractures don't properly displace, but if they don't have the right treatment, the metatarsal might move up a little bit.
Right.
And they find a year later, they come and the next one is hurting because the next one is taking too much weight. So we always have to have a look at the whole forefoot. We have to have a look at the bunion as well, because if there's a bunion issue and the second one starts to hurt, we can talk about bunions. But then if the second toe is causing trouble and you have a bunion, you need to sort out the bunion because the bunion is the reason for the second MTP joint. So yes, we need to look at the calf muscle, at the flexibility. It's a severe scale test where you test how much flexibility there is in the calf muscle with the knee bent and with the knee straight. We always have more movement upwards with the knee being bent, but how much movement is there with the knee being straight? Because when we run, the knee is straight when we push off. So if there's not enough flexibility there, it might be only linked to tight calf muscles that it causes the forefoot overload. So stretching of that, it doesn't always work. Sometimes in rare cases, we even do surgery. Sometimes we do combined surgery when we operate on the forefoot because there are operations to shorten the metatarsal and reduce the pain. But when a patient, for example, has bunion surgery, they start to get a bit of discomfort in the second, third MTP joint area, and we release the calf muscle, that leads to reduced pressure in the forefoot. And that takes away the pain, because that is a lot easier to recover from than operating on the forefoot.
Certainly from a physio point of view, we spend a lot of time people, buying the calf stretching boards, although you can pretty much make your own. And I always say to my patients, when you're cleaning your teeth in the morning and when you're cleaning your teeth at night, just stand on the calf board, 2 to 3 minutes, and at least then you get a good stretch of your calf. Some people you can probably, if you've got tight calves, you're not going to suddenly have floppy calves, are you? But maybe you can change 10% and that might make a difference to the pain.
I think even 5%.
Yeah.
If you do the rest, if you stretch your calf muscle, wear the right shoes, reduce your activities, let the inflammation settle a bit, that might be enough.
Yeah, absolutely. And the other thing that often gets talked about, and it's probably a good time to mention it, is podiatrists and the use of orthotics for this sort of forefoot pain. Now, obviously, it does depend what your diagnosis is because, stress fractures need rest, they need time to heal, and then you can probably crack on. But what's your thoughts around orthotics? Do you use it a lot? What sort of conditions is it good for?
Yeah, they can go back to running, but they might now realize that they should do something about their weight distribution in the foot. So I think even at that stage, seeing a podiatrist is good. I work with various podiatrists. It's important that we know them, that we communicate as with physios, as with GPs and everybody else. We need to have good podiatrists. As a foot surgeon, I work a lot with podiatrists because there are a lot of things that we can treat at an early stage or after something has happened in the recovery period. That doesn't mean when you get to orthotics, you have to wear them for the rest of your life. You have to wear horrible shoes. It's often some, especially elderly people who think now they have to go into the horrible shoes. No, podiatrists can give you just an idea what shoe would be best. They can put something into the shoes, some orthotics, so you don't have to wear the same type of shoe all the time. It's not that easy because orthotics take a bit of space, and the shoes might not be perfect for that, but it makes a huge difference. So with forefoot overload, whether it's Morton's neuroma, whether it's a stress fracture, stress reaction, capsulitis, having some shoes which have a bit of a heel raise, that's fine, but a bit stiffish sole, a bit rocker bottom sole, and enough space can make a huge difference. And in those, you sometimes add some orthotics, like a metatarsal dome, something that reduces the stress on the MTP joints, but takes a bit more weight further back. That can happen even with a Morton's neuroma, but a good podiatrist knows exactly what shoes are good for you, not 24 hours or whenever you walk, but when you walk a lot, you should have some good support in there. So
and certainly, I think if I had forefoot pain, which I'm pleased to say I don't suffer with, before I went to, unless I was really limping and I had a severe injury, I would probably look at changing my shoes first before I went down the line of the orthotics. And what's your opinion on, obviously, as we know, a lot of customized orthotics are very expensive. What's your thoughts around the orthotics that you can get off the shelf from Boots again or anything like that?
It really depends on the pathology. As you said, the shoes are more important. For most pathologies, the right shoes make a big difference. But the podiatrists don't always make custom-made shoes, orthotics. They just advise which orthotics might be best. So it might be off the shelf, a bit modified, and that often is enough. There used to be some podiatrists in London which charge, I think, by far too much. And as a podiatrist said, just for a piece of plastic. So it's not only about orthotics, seeing a podiatrist, it's about advice on footwear and probably getting some advice on what they can do, what exercise as well from you, but also from a podiatrist. But then, yes, sometimes even off-the-shelf ones might work. That really depends. In general, I recommend to see a podiatrist, but you can try that at first.
And we work with some of the physios in our clinic, and I do bits of it as well, where we also, as well as stretching the calf, we will give very specific strengthening exercises. Because obviously we've worn shoes since the age of whatever. So, and certainly there is some evidence to show that we do have quite weak feet as a population. We all know that as we get older, generally our arches drop. And so there are lots of specific exercises you can do that a physio or podiatrist will give you to strengthen your arches. And we do know that that's also going to have an impact, isn't it, on the absorption of shock when you're running, but also to put pressure on other areas of the knee, of the foot, instead of one area. And it's that repetition, isn't it? That bang, bang, bang.
And therefore sometimes even a bit of support, not custom-made orthotics, just to support you, but to exercise that you advise the patient to on the intrinsic foot muscles. Stretching on the extrinsic, the calf muscle, and working and strengthening on the intrinsic foot muscles.
And that's even further up the leg. So I saw a lady the other day who had a bit of a hip issue, bit of a foot issue, and we've actually just, she's coming to the end of her treatment now, but we've actually just left the foot and just treated the hip, and her foot pain's cleared up. And I think there's that whole argument, isn't there, that in terms of we know everything's related biomechanically, but do you treat something from the foot up, or do you treat something from the hip, or even further up down? And I've been doing this 25 years. I don't know the answer, but you just get a bit of a gut feeling with some patients that there's a driver and you need to treat the driver.
But yes, they link together. I had a few patients with bunion surgery, and they said, well, I've got a bunion, so I know my gait is normal. So if you straighten out my bunion, will I get rid of my lower back pain?
You can't guarantee it, can you?
But I had a few who came back, I don't have any lower back pain. I remember one lady, she had flat feet and bunions, so I sorted out her bunions and her flat feet. She came back, had both feet a year apart, come back years later and said, you know what, I never ever had migraine again.
Migraine.
Migraine.
It was the stress
of
a big bunion.
It's posture, and it can cause whatever. So yes, they
and big toes particularly.
They take a lot of weight.
They take a lot of weight, and you need extension. I think it's 60 degrees of toe extension for normal gait, which is an awful lot. And all you have to do is stand on your foot, put all your weight through your foot, and lift your big toe up, and you soon realise that they're pretty stiff.
We don't work enough on our flexibility and on the intrinsic foot
and
muscles.
probably shoes have been an issue with that evolution and development.
Yeah, we don't walk around enough without shoes.
Yeah,
that's a problem.
Exactly. But if you are going to start walking without shoes, build it up very slowly.
Yeah.
We see so many patients with forefoot pain that, you know, they go on holiday and start wearing flip-flops, or they go on holiday and for the first time they walk for a year with barefoot, and particularly barefoot in the sand. I mean, we see loads of stress fractures after that. I
think 30% of my patients come in, I've been on holiday.
Yeah, exactly. And you know what's happened. They've taken their shoes off.
Yes, they've done something that they normally don't do.
Yeah.
I had time I went running. I had time I did this. Whatever. Yeah. It's so often, it's linked to something they normally don't do.
Yeah. It's unaccustomed activity. But that's the same with shoulders. That's the same with backs. Yeah. I got pain after I did the garden for 2 hours. Exactly. When was the last time you did the garden? I've never done it. Yeah. You know, that's unaccustomed activity. And actually, the body needs that to adapt, but you have to expose it slowly, you have to build it up, and you have to give yourself time to recover and adapt and get stronger. And it's the same for all tissues in the body. Okay, so I think we definitely both agree, because we worked a lot together, is we've got to get, or at least try our very best to get a good diagnosis. Forefoot pain, metatarsalgia, these aren't diagnoses, and we're talking about a specific structure. And sometimes there's a few structures, aren't there? Yeah. But we're trying to do it. So do you want to just give us a bit more information about the sort of imaging that you might use to help with that diagnosis and how that fits in with what you do?
That's interesting. Most patients come in and they straight away want an MRI scan.
Yeah.
We don't always need an MRI scan. It's a good screening test, but if someone, I think had a stress fracture 3-4 weeks ago, ultrasound scan, X-ray, you see, don't need an MRI scan. Yeah. Ultrasound scan is very good for soft tissues, sometimes for bone, sometimes for joints, as you know. It's easy to use in the right hands, as you know, and you can use it straight away, and it's dynamic, and you can talk to the patient. So you test the joint, you look at the nerve, you compress it, does it reproduce your pain, and you see something. An MRI scan is very good as a screening test, but I think we underestimate the benefit of an ultrasound scan, or sometimes even a simple X-ray. So for the alignment of the foot, to see is the bunion, how bad it is the second metatarsal longer?
Is there arthritis?
Is there arthritis? Get an X-ray. That's very good. Weight-bearing standing X-ray. Don't do non-weight bearing.
There's a lot of people don't do, still in the NHS particularly, there's still a lot of non-weight bearing.
A lot of them.
X-rays.
They come even, a lot of them.
So that's X-rays.
X-rays.
You've mentioned MRI, and I think you've mentioned one of the, because obviously I do a lot of diagnostic ultrasound, and one of the key things is the dynamic nature of it. So you can squeeze it, and basically if there's a neuroma and you see it, it pops out. It is what it is.
And you can inject.
It's very, then there and then, if appropriate, you can do an injection. So one thing I want to mention about ultrasound, because I've been on the journey of ultrasound for around 15 years, and partly because of the number of patients you've referred to me and other people, and you know, once you've seen one person with forefoot pain, they then refer their mate with forefoot pain. I know I'm pretty good at forefoot ultrasound now, but I know that 10 years ago I wasn't as good as I am now for a few reasons. One is ultrasound is very operator dependent, but also if you don't see a lot of it, you don't get very good at it. So that's really important when you're having an ultrasound scan, and obviously the people we work with in our clinics are doing a lot of it. But if you're not seeing a lot of forefoot pain, particularly in runners, I think ultrasound doesn't necessarily afford the information that you could get out of it. And certainly I've been surprised with how many things I've seen on ultrasound that have not picked up on MRI.
Just had a patient recently somewhere, and MRI scan didn't really show anything, had pain in the midfoot, and said, there was no inflammation anywhere, nothing, just normal MRI scan. So I sent the patient to the person who reported on the MRI scan. He gave me a call 3 hours later. I'd done the ultrasound scan, so there's this, and this. One wasn't really relevant, but the other two were linked to that. And he couldn't see it, even in hindsight. I couldn't see it.
Even in hindsight on the MRI.
Couldn't see it. So the ultrasound scan is very good for superficial structures, soft tissue structures, and it's dynamic. But as you said, I put down the name, who should do the ultrasound scan.
And I
So
think
you get to-
ultrasound's really good I think it's really good for forefoot pain because you know the pain's coming from the forefoot pretty much.
Yeah.
And then you're using the ultrasound to try and prove a diagnosis or rule something out. Whereas MRI is really good for those patients, obviously, as you say, for bones and joints particularly, but those ones where you're not quite sure.
Yeah.
And maybe they've got 2 or 3 different areas of pain, which would be harder to really pin down on ultrasound.
Yeah.
So I think MRI for that more diffuse pain or that more widespread pain is
Good
quite
screening
useful.
test if you don't know what it is.
Yeah.
But not always necessary. But of course,
Still
it is
very
helpful.
useful.
Yeah.
Yeah, particularly
The
when
thing
you're going
is,
into
with the
the
ultrasound scan, I totally rely on the report.
Yeah.
MRI scan, I can look at it myself.
Yeah,
So
yeah.
therefore, absolutely important that.
And I think practitioners just do what they're comfortable with, what they're good at, what they're used to using. And the other thing is actually sometimes you need an X-ray, you need an MRI, and you need all 3 for those more complicated cases when it's not quite so clear cut. Okay, so we've concentrated a lot on diagnosis. We've talked a little bit about the physio side of it, which is obviously an area I'm quite passionate about, and I do feel there's a lot we can do from a physio point of view with these patients once we've got that diagnosis. But do you want to just go on to what I'm always interested in is asking surgeons, like obviously you're a surgeon and I'm sure you enjoy doing surgery, but what of those conditions that we've talked about do you feel should be seeing a surgeon potentially for surgery, and at what point? Difficult question.
Difficult one. Well, I'm a surgeon, but I think my conversion rate is extremely low.
Yeah, I can support that one.
So I always tell the patient when we discuss surgery, there's no condition that cannot be made worse by surgery.
Right, yeah.
So they all go, doesn't he know how to operate? No, to anyone, it can happen. There's not always a reason, but we don't do operation where I might have a look at it. You need to have a clear diagnosis. That's why history, examination, imaging, all that is important. But yes, there are some conditions where it's likely that you need to consider surgery. So yes, Morton's Neuroma, you treat them, podiatrist, physiotherapist, right shoes, ultrasound scan, injection, doesn't get better. Yes, taking a nerve out sounds strange. Well, we get a nerve for a reason, but if it's a reason for your ongoing pain, you take it out and it normally works very well. Yes, you get a bit of numbness. Yes, there are potential risks with it, but they're very low. It's a very successful operation.
Yeah.
The other condition, which in the forefoot, like capsulitis, so the overload of the second MTP joint, you don't really want to inject because it can lead to a rupture of the plantar plate. Going in there, doing a plantar plate repair, for example, which if it might be indicated, but it causes a bit of stiffness, you might want to consider shortening the bone. But again, if there's a proper plantar plate rupture, especially if there's some trauma related to it, we can repair it.
So that's that patient that's had a sudden stood on something or twisting injury of the forefoot.
Might have had previous symptoms, but then there's something that happens.
So there's a tearing incident.
The diagnosis, even with the best ultrasound, is not always easy.
Difficult, yeah.
But yes, going in there, repairing the plantar plate is something we nowadays can do. We couldn't do that 20 years ago, but we have the right instruments. Yeah. But yes, doing a shortening or osteotomy of the metatarsals.
So you're actually shortening one of the bones?
Most of the times, 2 of them, because if you shorten one, it could be that the next one is hurting.
Knock-on effect.
We might operate on the calf muscle, release the calf muscle to get more flexibility. There comes a point when you've explored everything and you think, well, now the only thing we can do is to do surgery. So I saw a lady self-funding just a few days ago, and she's got hallux rigidus, but really pronounced.
So that's a really stiff big toe.
Arthritic big toe joint for a long time. And she said, well, I think we need to do something. I said, well, we could do podiatry, physiotherapy, injection, blah, blah, blah. I had enough of it.
She was not interested.
She wasn't interested.
Yeah.
But then it might be that you offer that and the patient said, I just want to know what it is. I can live with it. She can live with it as well. But she's having pain as soon as she walks. So for her, I didn't want to tell her you need surgery because you could live without surgery, but you're just going to have ongoing pain. But she said, listen, I know how it is. I've seen the x-ray. I had it for a long time. You do something for me. So it depends on the patient as well.
Yeah.
And I had an elderly lady and she had arthritis in the big toe joint and she'd seen 5 different surgeons who all recommended the same thing.
Which would be a fusion.
A fusion.
Which is a very effective...
It's very effective.
Surgery, isn't
especially for men, they wear the same kind of heel height. It works well. There are some professional football players where it made stiff because you still can run, you can function.
But it
not
gets
ideal.
rid of the pain.
It gets rid of the pain.
Yeah.
And she finally said, well, I'm going to have it done.
Yeah.
So we did it. After 3 months, she was fine. I said, anything you would comment on, anything that went wrong or you were happy with? One regret. Why didn't I have it done earlier?
Yeah.
And it's pain-free now. And I was so concerned about it.
Yeah.
So that comes that point as well. You don't want to delay too
People
much.
get very, I think just at that sort of, as soon as you say fusion, they think so negatively about it. But the bottom line is their joint's almost fused anyway.
Yeah.
Because it doesn't move much.
Yeah.
So it's that little bit of movement that's left that's probably why they're getting the pain and the synovitis and
same with the ankle joint. You can fuse it, you can replace it. It all depends what the problem is, but a fusion can be good. An ankle replacement might be good. Same in the forefoot. You might resurface it partially, you might just clean it up. You can do different things for different stages. Yeah. But a fusion at the end, it's a last resort. But once it's completely worn out, it's if you can fuse it. Yeah, certainly.
Here's a question, Martin. That I'm just thinking of a patient I saw the other day who did have a stress fracture of the third metatarsal. And he wasn't in that much pain, but it was confirmed. And I said, look, you need to stop. You could make this worse. And you know what runners are like. Like, what do you mean worse? Like, how bad? And I'm like, well, the bone could snap and you need to have surgery. I wanted him to stop running. Does that actually happen? Where the stress fracture will then go into a full fracture and then you have to pin it?
Well, it's not that common in 2 and 3, but it can happen. I had one patient, for example, a lot of patients don't know they have a stress fracture.
Yeah. For a while anyway.
It just hurts and hurts. And it's not common to need to operate. But on the fourth one, yes, because there's more flexibility there, they might get away with it. Fifth
so it ends up a bit displaced as well.
Yeah. There's a bit of a kink in it. Yeah. And the fifth one, cavus feet. That's it's not like the base of the fifth metatarsal. It's a bit further down.
Right. Yeah.
So and that can be cavus feet overloading. Active people get a stress fracture, heels active.
So cavus is where they've got those real high arch feet.
They overload on the outside. The fifth metatarsal.
Those people that you see walking over the bridge with on the outside of the
so
feet,
they have a lot of weight. First metatarsal, fifth metatarsal, they walk like this, and those ones often need surgery. Second, third, not very common, but yes, it can happen. I had to do a few so far.
There's cavus feet. The people that when they're walking with slightly damp feet, you look at their footprint and all you see is two sides of the foot. There's nothing in the middle touching it. It gives us a lot of indication that actually as to where they're putting weight.
They're stiff feet.
So their shock absorption is really poor. They're very heavy normally.
They're heavy. What is interesting, they normally don't have a very tight calf muscle. Whereas flat feet are very flexible, but they often have a tight calf muscle because they're so flexible, they dorsiflex with the feet in a valgus position. They get up. Whereas the cavus feet don't need...
No.
I mean, they have enough flexibility. They don't need often anything done to the calf muscle.
So so basically the message with surgery from a surgeon is it's very rarely going to be your first port of call. And actually you need to look at probably exhausting all the other options, which is often a multidisciplinary team approach. Your physio, your surgeon, your podiatrist, and obviously other people in that as well. And it's probably, if you've got forefoot pain, you've got to look at what shoes you're wearing. You've probably got to look at some sort of rehabilitation and looking also potentially at orthotics if things aren't getting better. One thing we haven't talked about, which obviously is originally how we met, is the role of ultrasound guided injections and how you see that fits in to the overall care pathway.
I think ultrasound scan has always been underestimated in this country. I mean, initially when I mentioned, well, I'm going to send you to someone who's going to do ultrasound scan, I'm not pregnant. So
you still get that now. Is it a boy or a girl?
Exactly. It's just so interesting. It's good for diagnostic purpose, but it's good as a treatment. As a diagnostic kind of, well, you inject local anesthetic somewhere in the joint, second MTP joint, you inject in there, no risk associated with it. Pain disappears. You know where it's coming from. It's the second MTP joint. It's not a nerve. It's not something else. So there's that role of a diagnostic injection, but as a treatment for joints. So I remember 8 years ago, woke up one morning, couldn't go to work, pain so much, thought I had calcified muscle, something in my shoulder. Couldn't go. Went in, saw next day my radiology colleague. I said, I've got something in my shoulder, there must be something wrong. He said, no, your shoulder looks good. It's your AC joint. Do you want to have an injection? I said, yeah, please. Put it in there.
Got surgery
Walked in like that. Walked out with no pain.
I mean, I'm biased, as you know,
that's-
because I do lots of
it's
injections, but if
it's-
you get the diagnosis right, there are conditions
Yeah.
that respond very well. And obviously, at Complete, we can offer that diagnostic ultrasound, and if appropriate, there and then carry out an ultrasound guided procedure. And I think with forefoot pain, and in fact any foot pain, it can be tricky, even with all the imaging in the world, to know where is that pain coming from. And I always say to patients, look, this is a therapeutic injection because we want to get your pain better. But actually, we know if your pain gets better, then we have a very good idea potentially of where that pain is coming from. And that can actually really help us kind of moving forward with how to treat it, and maybe help with prognostics as well.
Absolutely.
In terms of how quickly things are going to get better.
It's also good for the patient to have that period of no pain. Oh, that's how it is. I want that.
Yeah.
So yes,
They've forgotten sometimes.
They've forgotten. And yes, I want to go down the route of surgery because I'm so much better now. Or, well, it's okay, I know what it is, but I don't need to have surgery. I'm happy to continue with conservative treatment. But to get the diagnosis right with an injection, even local anesthetics is good. But yes, so second MTP joint, third, I'm not keen on cortisone because it can lead to problems. I had a patient, keen runner, had a cortisone injection into his plantar fascia years ago and did very well, came back a year later, said, can I have another one? I said, yeah, but no running, as you know. So he then came back later on and said, I've got a lot of pain. I said, what happened? Well, I had the injection work perfectly well, went to New York, ran the marathon, in 2/3 through the marathon, ruptured.
Yeah.
It ruptured.
It's definitely a risk, isn't it?
There is a risk.
For plantar fascia.
For plantar
specifically,
fascia, for any structure. Not common with plantar fasciitis, of course not, but it can happen.
Yeah.
And it can happen anywhere.
Yeah.
It's more common lower limb. Upper limb doesn't happen too much, I guess. Well, you know more.
It's
that,
definitely
it's a lower
rarer,
limb.
but lower limb, weight-bearing joints
Exactly.
and tendons.
And small joints, second, third
fascias,
MTP joint. First MTP joint, I don't have any issue. All the other joints, I don't have any real issue.
Neuromas, I don't think I've ever had any specific issues.
Tendons.
Joints have generally been okay. Tendons are the
tendons
thing,
are
aren't
the
they?
thing. Achilles tendon, and I spoke to
plantar
someone
fascia.
recently as well. He thinks probably the most likely tendon to being at risk is tibialis anterior.
Right.
That rupture.
Yeah.
There was a radiologist who said, because I discussed it with him, I said, there is something, would you consider doing it? And he said, well, tendons, we can probably do it. If the tendon is absolutely fine, I'm just concerned about the tibialis anterior tendon.
Well, I think that's fair because it's definitely one that ruptures.
Yeah.
And it's the same as the Achilles. At all costs now, we will avoid steroid. There's always the odd occasion, as we know, but generally speaking, we would avoid steroid in those areas.
Yeah.
But again, it's like everything. It's like surgery. It's a question of, first of all, getting the right diagnosis and then basically discussing those options with the patient. And actually, as you say quite rightly, the patients that want to go for surgery are the ones that are fully aware of what's happening and they tell you, I'd actually like to go ahead with the surgery.
I advise, patient decides.
Exactly. Give them as much information as possible, although you have to be careful with what's out there on Google.
Some don't even want to hear what the operation is like, but they need to know the basic stuff. Normally they want to know, and they sometimes informed, sometimes they get the wrong idea from Google, but often it's good if patients have a basic understanding of it. It helps,
Cool. Okay, well, I think we've come to the end. Thanks very much for your time today, Martin. Always good to talk to you. And I always like doing this because we share a lot of the same thoughts, and it's nice to know that we're sort of on the same page. And I think that really reflects with the patients that we see. They know that we communicate well with each other. We know we're genuinely interested, enthusiastic about what we do. We love what we do. And I think, I certainly look forward to sharing lots more patients, particularly the forefoot, because we know it can be a challenging area. So thanks very much for your time today.
Thank you, Chris. It's always good to know with whom you can work well. You get feedback and makes a big difference. And the patients love that as well.
They do. Brilliant.
Good. Thanks, Chris.
Thank you.
Thank you.